It's a pleasure to be here. I'm going to be focusing on the importance of local control in head and neck cancer, and will hopefully reinforce some of the really important concepts that Dr. Rabin introduced earlier. Similar disclosures. So I thought I'd start with a couple of clinical cases just to illustrate, how things usually go for real head and neck patients. A little bit more in depth into head and neck cancers, and then I will also present some of the early data from the 102 study that's been conducted in Europe. So I'll start with a case of a 52-year-old gentleman, former very light smoker. He presented with a growing neck mass, which is pretty common in this group of patients, difficulty swallowing, some hoarseness. You can see his initial CT scan on the left, which is basically a slice through his neck and the back of his tongue, that he has a tumor that's, let's see if this works. A tumor that's arising from his base of tongue, part of the oropharynx, as well as a metastasis to a lymph node. And you can see on his endoscopic exam a large tumor here in the back of his tongue. And I'll introduce a few of the areas where we typically see head and neck cancer. So in this patient, as many patients, there are tumors that start in the back of their tongue, in the tonsils. Those are considered oropharynx cancers. You also see that in the study that I'll be talking about later, there are patients who have oral cavity cancers. Those are ones that can arise from the tongue, the gums, the sides of the inside of the cheek. And so there are various areas where head and neck cancers develop, and you'll be hearing about more of these as we go along. He had a biopsy that showed that it was a HPV or human papillomavirus related cancer, as you heard a little bit from Dr. Rabin about already. And you can see that we attempted to do a sophisticated radiation treatment plan, not like the simple fields that were done before, but with this dose-painting, intensity-modulated radiation therapy, where we really give a high dose to the tumor, the involved lymph nodes, but we also treat all the lymph nodes in both sides of the neck, because we think there are tiny tumor cells that are sitting there in the other lymph nodes, and so we treat a whole area of their head and neck. With a high dose of radiation here. You can see we are trying to spare important areas such as the spinal cord here, so we kind of shape the dose of the radiation. And this is high quality, sophisticated radiation right now. But he did have to go through 7 weeks of radiation, which is standard, 5 days a week, 7 weeks of radiation. And he also had concurrent chemotherapy with this radiation, which, as we've heard, is really important to the success of these treatments, really combined chemoradiation for these patients. He did have a really good response. You can see we usually use PET scans where we can see areas of active tumor light up. This was his initial PET scan before treatment. This was his PET scan after completing treatment with a complete response. But unfortunately, he did have a lot of side effects and toxicities, as most head and neck cancer patients will have with this standard treatment. He had a lot of pain, a lot of sores in his throat. He needed to be on pain medicine for several weeks, even months after he finished treatment. He had really bad dry mouth, no taste for several months after he finished too. This is pretty standard for patients who undergo a standard course of chemoradiation for head and neck cancer. The second case is a gentleman, older, in his 70s, had a heavy smoking and drinking history. This is also something that we see pretty commonly with head and neck cancer patients. He had a HPV negative cancer, which we do see often with heavy smokers and drinkers. He was not able to have cisplatin chemotherapy, and so was treated with radiation plus cetuximab, which we now know is less effective than cisplatin would be. We can see that on his pretreatment PET scan, he had similar area in the base of tongue here, similar to that other patient, as well as a lymph node here with active tumor. We gave high-dose radiation to these areas, but unfortunately, after treatment, he still had disease in these exact same areas. So you can see this case illustrates that a lot of times local control is not sufficient for these patients with more aggressive disease. And this also illustrates that head and neck cancer tends to be more of a local disease. It's something where we need to give treatment to the local area in the head and neck, the lymph nodes, but it doesn't often metastasize to other parts of the body. It can, but first and foremost, it's a local disease where local treatment is really important.
And so you can see again, he had persistent disease after his treatment. He was unable to have surgery to try to remove these areas. He was tried on immunotherapy afterward and had toxicities from that. And so he ended up having a bad outcome. And we can see when we look at these two patient cases, kind of, both we need better treatment options, both in cases where patients are curable and in patients with aggressive disease. So you can see with this first patient, he had a good response to treatment. He was, he's cured right now, but he had a lot of bad side effects affecting both his short and long-term quality of life. And so we need less toxic treatment options for these patients who have favorable disease. In the second case, this patient had high-risk disease. He was unable to have standard chemoradiation, and he ended up having a poor outcome. He had toxicities with immunotherapy. He ended up going to hospice and dying a year after his diagnosis. And that was all from local disease. So we need better local control for these patients with more aggressive disease. A little bit more background on head and neck cancer. So this is a fairly common cancer worldwide. We can see worldwide that there are more than 500,000 cases. It's one of the top 10 most frequently diagnosed cancers in the world. It does result in a large number of deaths, too. In the United States, it accounts for approximately 3% of all cancers. About over 60,000 patients will be diagnosed every year in the U.S. And in Europe, it's also a similarly large number. About 250,000 will be diagnosed every year. You can see that in terms of outcomes or where patients get it, again, it's more of a local regional disease. So majority of patients either have localized or regional disease that has gone to the lymph nodes in the neck. Some patients do have distant metastases, but again, it tends to be more of a local disease. The survival really varies based on how extensive the disease is. So for localized disease, the survival can be quite good. This is one of these cancers that we can really cure, and we can cure with radiation and chemotherapy. So for localized disease, we can see survival at 5 years of around 80%. Of course, if patients already have distant disease, the survival gets worse. In terms of who gets it, the traditional risk factors for head and neck cancer were heavy smoking and drinking. Smokers have an increased risk of 5 to 25 times over the general population. But we are seeing, as you've heard from Dr. Rabin as well, an increasing number of patients with HPV or human papillomavirus-associated head and neck cancer. This now is accounting for a large majority of patients with oropharynx cancer, the ones that are in the tonsil and base of tongue. This is the same infection that's causing cervical cancer and a reason why a lot of children now are being recommended vaccination with HPV. So it's an increasing source of head and neck cancer as well as other cancers. What we've seen is that we're seeing a lot more younger patients come with head and neck cancer that are HPV related. They may not have had much of a smoking history. It's young patients with HPV related head and neck cancers. And these fortunately tend to have better outcomes than those who are HPV negative or smoking related. These patients have better cure rates, do better with the standard treatments, but if they are going to be living longer and suffering from the side effects of treatment, we need to find better ways to have a lower toxicity treatment for these patients. You can see here some additional risk factors for head and neck cancer: male gender, older age, some occupational exposures, family history, Asian ancestry is associated with certain head and neck cancers, exposure to prior radiation or other virus infections. But I would say primarily for the head and neck cancers, we see a lot of smoking as well as now HPV-related cancers more and more. As you've heard from Dr. Rabin already, the treatment of cancers in the head and neck is really, really difficult because it's in a very small part of the body with a lot of important critical normal structures there. We have, the spinal cord, the brain stem, all of your muscles that help you with swallowing. These are all very important areas that are hard to really treat the tumor well while sparing these regular structures from radiation. Treatment requires multidisciplinary care between a lot of disciplines. So we have surgeons involved, radiation and medical oncologists,
really important to have good initial diagnostic evaluation with radiology and good pathology evaluation. We are now routinely looking at the HPV status of all the cancers that could potentially be HPV related. We have a lot of support services such as speech and swallow therapy, nutritionists, dentists, physical therapy and rehab because of all of the side effects that come with head and neck radiation. Early cancers can often be treated or resected with surgery, but for locally advanced cancers, we usually need to involve radiation, oftentimes with chemotherapy. Sometimes we need all three, so it's a very challenging area to treat. As we've talked about before, many patients can be cured with with head and neck cancer, but we really do need better local therapy in several ways. So for patients with aggressive or poor biology disease, for the patients who are ineligible for sensitizing chemotherapy, and in this 102 study that I'll be describing shortly addresses the patients who are ineligible for the chemo that's needed to make the radiation work better. And then patients with recurrent cancer, and Dr. Seward will be talking about the 1100 study and patients who have recurrent head and neck cancer and can potentially benefit from better local therapy there too. The toxicities remain a big problem for many patients, for most patients with head and neck cancer, and especially for patients who have a good disease outcome. We really need to reduce those toxicities. So I think in the future we're going to be seeing treatments that are tailored based on the disease extent and biology, but I think overall better local therapy, less toxic local therapy is going to be key. Just some examples of some of the toxicities that we can see with patients who are treated with chemoradiation for head and neck cancer. Short term, similar to the first patient I talked about, you can have painful sores in your mouth, you have a lot of mucus, you feel like you have a terrible cold for weeks and weeks. You can have pain with swallowing. A lot of patients will need to have a temporary feeding tube to be able to get enough nutrition while they're on treatment. Patients will have dry mouth and taste changes. A bad skin reaction, like a bad sunburn that can peel, and a lot of patients will have fatigue, very bad fatigue with both the chemo and the radiation. Long-term taste changes can last for many, many months, even over a year. They can have permanent taste changes, dry mouth similarly, a lot of swelling and scarring in the neck, effects on their thyroid hormone, damage to their nerves. Jaw stiffness, damage to their bones and teeth. Some patients will have really bad problems with their teeth and dental problems afterwards. So it is a very toxic treatment to go through. So I was very excited when I saw the initial data from the NBTX 102 study, and so I'm happy to share some of the early results that they've seen with this. This is the phase 1-2 trial in locally advanced squamous cell cancer of the oropharynx, which are the cancers in the tonsil or the base of tongue, as well as oral cavity, which are those in the tongue or the jaw or the tongue or the gums or the inside of the cheek, for example. This is a study that's ongoing in Europe. This is a poor prognosis patient population. They're stage 3 and 4 cancers, elderly, frail patients who are not eligible for standard chemotherapy, so they're receiving radiation alone. This did allow all HPV status patients. So this is a frail patient population, only eligible to receive radiation. This is a population that typically we would think would have poor outcomes. And we can see that in general, with radiation alone, we have very poor success in curing these patients. These are 3 studies that had patients that were treated with radiation alone. 2 of these looked at specifically the elderly population, and we can see that with radiation alone, the median survival for this population is just around a year, so it's very poor. And so you would expect that patients on this study would have a similar survival outcome. Typically with oropharynx cancers, we tend to have a little more success treating with chemo and radiation. I will say that with oral cavity cancers, we usually have very little success even treating these patients with just chemo and radiation. It's oftentimes we think of it as more of a surgical disease site where we try, if possible, to have surgery before chemo and radiation. So these patients really expect to have a poor outcome if they're not able to have surgery and are just being treated with radiation alone. So in terms of the side effects from this phase 1 portion, we can see that in terms of adverse events related to the nanoparticle versus the tumor injection,
the majority of the adverse events were from the injection itself, very low grade, and seen more with the higher doses of the nanoparticle compared to the lower doses. But again, very low grade and really primarily related to injection. This is very recent data. I think it was just presented maybe a week or two ago at the ImmunoRed conference. And so this is the most recent data from this phase 1 portion of the study. And we can see that the study is evaluating increasing doses of the nanoparticle together with radiation, and that's it. No chemotherapy, just radiation and increasing doses of the nanoparticle. We can see that at the lowest dose level, pretty much patients did about what we would expect with radiation alone. The patients all died before a year, and I'll say that the length of these bars represents their survival or follow-up. Any stars represent patients who have died. The X's represent disease progression. The green arrows are representing a complete response. The yellow arrows or triangles are a partial response, and then stable disease is with orange. So we can see with the low dose level, we pretty much didn't see any long-term responses. We can start to see with the higher dose levels, quite a few complete responses, which is very impressive for this patient population. And we don't yet have as much follow-up yet for this highest dose, but you can see that there are several patients in these higher dose levels that have complete response. And impressively, the patients who have survived over a year are continuing to survive, many of them over 2 years, which is not something that we would expect with this patient population. The other thing that I wanted to point out is that a couple of these patients who have progressed in these higher dose levels were patients with really aggressive oral cavity cancers, and those are patients that we really wouldn't expect to cure, even with chemo and radiation, let alone just radiation alone. So I'm very impressed with these data, and I'm looking forward to seeing how the further follow-up are with the higher doses. And I think the other important part of this is that it has an excellent safety profile. We really haven't seen any severe adverse reactions, and there's quite a significant level of complete response. And so I'm hopeful that this will be a way for us to improve local therapy while minimizing toxicity for this treatment population. Certainly, this study is looking at the more frail and elderly patients, but I think this can be applied to our other patients who have favorable disease and potentially limit side effects too. So I think that's where I'll end, and I'm happy to take any questions. Uh-huh.